All right. Our second to last speaker, Dr. Alekos Theologis, who is an associate professor of orthopedic spine surgery at the UCSF, and he's going to talk about radiolucent technology in treatment of spinal tumors.
All right, wonderful. Thank you, Lionel, Kyle, and Lee for the invitation again. This is a tumor talk, and tumor talks require team effort, and I thought I'd take this opportunity to thank several people. One is Aaron for coming to war with me on all these hard cases. The fellows, Austin, Asr, and Abdullah, for taking care of the patients in the hospital, and then Rosa for taking care of all the patients in the clinic. Without you guys, we could not do this. So to kick it off, we'll be talking about radiolucent technology in the treatment of spine tumors. And these are my disclosures, two relevant ones. I'm a consultant for both companies that make radiolucent screws, Carbofix and Icotech. Hopefully, because I consult for both of them, I'll give you a relatively unbiased perspective, or a very biased one. So by way of background, 1,000-foot overview, tumors, there's primary tumors and metastatic tumors. And what I'll be talking about applies to both. They come in extradural and also intradural. No matter what surgery we do for them, they're really amazing surgical endeavors. And for the surgery has been demonstrated to provide significant benefits for the for the primary group, provides a survival benefit. And for the metastatic group, provides significant functional improvements. Now, surgical resection is only one piece of the puzzle. When we talk about tumors, there's short-term goals and long-term. In addition to resection of the tumor adequately, you need to preserve neural function. You need to provide a stable and durable reconstruction of the spine. You need to adequately reconstruct the soft tissues. Plastic surgery is key for this. And then long-term, they need to have timely administration of systemic and radiation therapy. I need to monitor for recurrence, and then you also need to assess for complications that may jeopardize the neural structures, hematomas, infections, et cetera. Now, part of the talk here is to talk and try to link the reconstructive options we have to potentially some of the longer-term outcomes. So the current quote-unquote standard right now is metallic instrumentation. Not sure 4 rods is the standard, but anterior column reconstruction with a titanium cage and posterior-based rods and screws is the mainstay of treatment now. However, there are significant limitations of using metallic instrumentation for tumors. The first problem is that it jeopardizes radiation planning. This is a slide that one of our radiation oncologists, Steve Bronstein, provided to me. And I don't know what any of these things mean, so I'll take his word for it. But it affects how they plan for radiation. Somehow the scatter prevents the dosing. They can't provide as high of a dosing as they want, which may jeopardize their ability to treat the more radio-resistant tumors with appropriate radiation. Now, the second problem is postoperative imaging, and this is not only for spine tumors, it's for all of spine. And this is really, I'll show you a case that got me maybe a believer in radiolucent technology. So this is a gentleman, first or second year practice, 60-year-old male, had a primary leiomyosarcoma at T9. You can see here on the axial and the sagittal, it's confined just to one vertebral body. No metastatic disease, so the plan was an en-bloc resection. We took it in 2 stages. The first was a posterior release, and then what happened 2 days afterwards is he woke up with paraplegia. His blood pressure dropped into the 60s overnight. So we thought, well, this is a spinal cord infarct, or is it a hematoma? So we didn't have really time to get imaging. So we just took him on the weekend with cardiothoracic surgery, did an en-bloc resection through the front. And postoperative imaging, we wanted to see if there's any residual stenosis, if there was an infarct. And with the metallic instrumentation, we couldn't see anything. So we're kind of blind to the whole thing. So it brings up the question is there radiolucent alternatives, both for the anterior column and the posterior column? And we'll go through several. So if we focus on the anterior column, the inner body first, these are all many types of interbody options you have, from very old morselized graft and structural allograft, which my partner still uses commonly, the back cages, and then a variety of cages, titanium, PEEK. And the radiolucent ones, I'll highlight here, the morselized graft, the structural graft, and the PEEK cages that have interfixation through them or not. All the interfixation screws are titanium, so it's not a pure radiolucent option. Now, this is ALIFs, but lateral or ATP options, you do have standard PEEK cages, but you don't have plating that is radiolucent. Now, for the anterior column, when it comes to reconstruction of a corpectomy, I think several things to discuss. There's non-cage options and there's cage options. The non-cage options, an older technique, PMMA, is shown on the left here. There's also use of structural allograft, femoral ring. You can use the rib. There's a variety. And then you have radiolucent cages, so static cages, and then expandable cages, so very similar to your titanium options, and then come with a variety of footprints, circular as well as rectangular. And then it brings us to the posterior column stabilization pedicle screws. So as you see on the upper left there, the shaft is radiolucent and the tulip heads are titanium. And then the alternative is an all carbon fiber. So the shaft is radiolucent and the tulip heads are also radiolucent. And then you also have rods, PEEK rod, which is not a new concept, but the newer ones are carbon fiber rods. So how do these compare? How do they stack up to the current standard? In asking several questions. Biomechanically, are they similar, equivalent, inferior? Do they improve radiation planning and delivery? Do they improve postoperative imaging? And then ultimately, do they improve clinical outcomes? So biomechanically, several studies have demonstrated that they're equivalent, and the one on the bottom says that there may be slightly less micromotion. I wouldn't go as far to say that they're superior, but I would consider them not inferior. In terms of radiation planning, this is a study we're doing with RadOnc with Steve Bronstein, and we found that in phantom studies showed up to 10% difference in dose measurements and delivery with titanium. So the ability to deliver radiation was compromised in the setting of titanium, and it was improved with these carbon fiber PEEK. In terms of postoperative imaging, so this is a study from the European group, 35 patients, metastatic and primary tumors, and their conclusion was that carbon fiber reinforced PEEK reduce image artifacts on CT and MRI. I'm going to go to say it depends, and this is where you can kind of tailor your surgical strategy to the tumor. So I've gone through a variety of generations and mixed and matched technologies. So I'll go through what I think is the right way of using it. So if you have a metallic anterior column, so corpectomy with a titanium cage, whether or not you have radiolucent screws above and below, as in this case, the imaging postoperatively is significantly compromised. This is a patient who went paraplegic post-op day 1. We didn't know if it was an infarct, et cetera, so we got an MRI. This didn't really tell us anything differently, so we took her back and explored. So I'm not a big fan of using titanium expandable cages in the anterior column any longer. Now, when it comes to the radiolucent anterior column, so you use a expandable PEEK cage or a radiolucent PEEK cage, does the type of posterior instrumentation matter? And there's a variety of ways you can look at this. So you can just make all posterior screws and rods. You can do a combination of the two, where you can put carbon fiber rod screws above and below the corpectomy site, but ones that have titanium tulip heads. So it's still metallic instrumentation posteriorly. And then you can do the same thing, but use the carbon fiber rods. I think for these two are probably the better of the three, and particularly for tumors of the anterior column. So this is a patient metastatic breast cancer at T8. We performed this hybrid construct, and the imaging, you can see at the screw level, is pretty pristine, and it's hard to argue with this. Now, this does require 1.5 Tesla because the titanium tulip heads will jeopardize the imaging if it's 3T. This is a patient who used carbon fiber rods in addition to this hybrid box construct. Again, metastatic breast cancer, and at the corpectomy level, again, pretty pristine imaging. And these images are hard to argue with. This was also a 1.5 Tesla MRI. Now, all radiolucent instrumentation, so this is where the anterior column is reconstructed with a peak carbon fiber cage. The screws above and below it are carbon fiber shaft, and the tulip heads are also carbon fiber. These are the ones that I use in the setting of tumors that cross the equator, or any tumor that has that's all posterior. So anything with a posterior-based element to it. This is the type of surgical strategy that I'll implement. So this is a patient recently, 50-year-old male, T12 chondrosarcoma, no metastatic disease. So we pursued an unblocked resection for him. And here again, we created a box of radiolucent instrumentation above and below, reconstructed the anterior column, expandable peak cage, and then we were able to create a 4-rod construct across it with a carbon fiber crosslink. We put titanium instrumentation at the top and the bottom, and then linked in a long carbon fiber. So that whole area was carbon fiber. This is the postoperative MRI, 3 Tesla in the hospital. This is a patient who was going to get proton beam therapy in New York. And so this was the planning for that radiation. And again, you can see here, even in the setting of acute, has going to have some bleeding around there immediately postoperatively. The imaging quality was pretty pristine. So that brings us to whether there's any real clinical improvements. Here, there's significant data that's lacking. I think this is room for improvement. This is a study recently from Daryl Lau, one of the old residents in neurosurgery. He performed a review of 11 articles looking at patients that had titanium instrumentation versus those that had the carbon fiber, and relatively equivalent implant-related complications, rates of reoperation, and then local recurrence. I think this is somewhat of a damning finding. If they're able to provide better radiation, then local recurrence potentially should be reduced. So I'm not sure if this will be borne out in other studies, but this is an area that I think is important to study further. There are significant constraints to carbon fiber technology currently. There's no cervical system. I think there's one coming out soon, but it's not available. You can't bend the rods. They had pre-templated or 4 templates that you can try to fit to your spine, but especially in the lumbosacral junction, I'll show several case examples of this. It can be difficult to achieve the right shape. The rods are all 6.0, so if you have a screw system that only accepts 5.5 tulip heads, then you can't use the rods in that. The titanium tulip heads, there's benefits in terms of reduction of the rods to the screws. But again, it does jeopardize visualization of the posterior aspect of the spine. It requires a 1.5 Tesla MRI. There's no pelvic screws options, and there's not a complete set of radiolucent connectors, lateral connectors to the pelvis. And this is a patient, primary lumbar chondrosarcoma extending from L2 down to the sacrum. And we did an unblocked resection. And this kind of shows how you piece together all the instrumentation. So on that right side where the primary tumor was, we couldn't put any screws in. And so we just put rods that connected to the screws above and did iliac fixation. And we put 4 rods across the radiolucent cross connectors. And then we couldn't get fusion from the back. So we did interbody reconstruction with direct laterals from 2 to 5, and then a peak type cage at L5S1. She's about 5 years postoperatively and has had no local recurrence. And then this is postoperative imaging, again, pretty pristine in terms of monitoring for recurrence. Last case I'll show is a patient with metastatic osteosarcoma. The goal here was not unblock resection, but did want to provide the ability to provide radiation. Osteosarcoma is relatively radio-resistant, so we wanted to be able to provide the highest dose possible. So we did a L5 partial corpectomy, L2 to pelvis reconstruction. Again, we tried to create this box of radiolucent technology, but again, shows you the limitations of the pelvic fixation, S2AI screw here, and the connectors proximally. So we tried to keep all the titanium as far away as possible. And the postoperative imaging, despite having that there, was pretty good again. So in conclusion, care of spine patients that have tumors requires a multidisciplinary effort. Outcomes are highly dictated by adequacy of resection, but also neoadjuvant, adjuvant systemic therapy and radiation. Postoperative imaging is critical for radiation planning and detection of tumor recurrence, as well as neural compromising pathology. Radiolucent spinal imaging, pedicle screws, interbody cages, corpectomies provide benefits for spine tumors, better imaging. I think that's hard to argue with. It improves radiation planning and provides safer radiation planning, but does that actually affect clinical outcomes, TBD? And there are several limitations in terms of the current instrumentation. I think this is an area for potential technological advancements. So thank you very much.
For a great talk. I use carbon fiber instrumentation for some of the metastatic tumors as well. One thing that I didn't really like is that it's hard to contour it, especially if you're going longer segment. Do you have any way to kind of work around that? Do you use multiple rods and connect them, or how do you work around that?
Yeah. So one technique that I've tried to do is to break it up into small segments. So the area that you really need the carbon fiber is around the tumor section. So I'll try to put small rods that bridge that. And then the levels above, I'll put titanium. And then I'll run longer rods lateral to it. That does require at least 3 points of fixation above and below, because if you only have 2, then your connector options get a little bit wonky. But yeah, if you can break it up into smaller segments, that makes it a little bit easier.
With carbon fiber plants versus titanium, do you think that's because you're able to see better, and the ability to detect the recurrence is much better, given the fact that you'd see better?
Yeah.
So on the titanium, you might not be able to see that recurrence because it's just you can't see anything, right?
Yep, that's a good point. I think the percentage was relatively low, but 4 or 5% may add up over time. That's one definitely possibility. It was a review article, so they didn't give many details on what the recurrences were, and it was a mixed bag. It was metastatic, primary, but I think that is the next area to tease out.
Alekos, thank you. 2 questions. One, where are these instruments failing? Is it mid rod tulip screw interface? And then number 2, what do you think or when is it going to be cost effective for broader indications? Because I feel like this has potential for degen setting, a patient with chronic pain. You can't see stuff after surgery. So those 2 questions: where do they fail, and when do you think it'll be cost effective?
Yeah. So the failure mechanisms, I've had one fail, 18-year-old kid with a primary sarcoma. I only put 2 rods across it. It was a multi-level corpectomy, and it failed right at the junction of the rod and the tulip, so right next to it. The other failures have not been well reported, so I don't exactly know, but that's my hunch, is that that's where it's occurring. I don't know the answer to the cost effective aspect. To manufacture these, talking to the companies is very, very costly. So for them to break even or make any real, make it worthwhile, they have to charge pretty exorbitant costs. So I don't know, but I do think that this has other applications. I know this is a tumor talk. I'm starting to use radiolucent screws at the top of T10 to pelvises, because that's an area that has an issue with adjacent segment disease. Get a big thoracic disc herniation there, stenosis. Not exactly sure what's going on. So we'll see if that has utility. But yeah, I think there are other indications for it, but you're right. There are hospitals that are not willing to take the cost on that. But I want to say that at UCSF, this was scrutinized significantly. And what they found after a year of usage was that the contribution margin was actually very high. So they were happy that for us to continue to use it. You lose money on the Medicare patients, but you make a lot of money on the patients with private insurance. And altogether, on average, the hospital was not, they didn't shut it down. Great, thank you.